Hello again. Today we are going to be discussing the surgical procedures that are most common to treat pseudotumor cerebri. I would like to structure them, and this is just for my own sake. This is not a medical format or a structuring, but I would like to structure them in such a way. There is the ophthalmological surgery, which we talked about in the last video, which is the sheath eye fenestration. Then there are the neurosurgical procedures, which are the ones called basically shunting. And this includes an LP and a VP, VA, which we're going to talk about today. And then I'm going to just touch on, I will do another video more in depth on the surgery called ICE. That's an acronym, ICE, and which is more of a pediatrician neurosurgery surgery, but it's basically at the step where I'm at, and I have been at for a while. I basically the success rate is not high enough for me to proceed. So I'm being watched closely, and the situation is being handled in other ways, which I will talk about also. So that we're trying to avoid that surgery at all costs. In any case, so today, we already talked about the left eye sheath fenestration. So let's talk about what is basically considered within the field of neurosurgeon. What do I mean by that is you need a neurosurgeon to perform these. Except please understand, except for the stenting. That is yet another surgery which is usually performed by an interventional radiologist, which I also do want to discuss. Sorry, I apologize about that. So the first one is called an LP shunt. This is a lumbar peritoneal shunt. Shunt meaning catheter or tubing, plastic tubing, which is placed from your lumbar sac, which lumbar sac is the sac where your and very crudely said, where your nerve endings end up from your spinal column. So it's placed there and threaded all the way around to your peritoneal sac. And this is the sac where your organs are held. And these are basically your intestines and everything else, your belly. This is usually the first procedure, although many neurosurgeons nowadays go straight to the VP shunt. But especially when I began having procedures, and this was first performed in 1993, they had to have a revision because it didn't work. My body has not responded well to them. Later on, I had to have yet another one, and it got infected. So my body did not do well with LP shunts. But this is usually one of the first procedures at my time they did. Not a very high success rate in terms of catheters. They do turn to clog quickly. Again, this may not be your situation. You may be very happy with an LP shunt. I am just telling you anecdotally what my experience has been, what I have heard from people, and what I have read. So please do not take my word for Bible. This I am not giving advice. I am just telling you my experience. Second procedure. LP shunt, you basically stay in the hospital minimally 1 night. If you have any complications, maybe 2 nights, but and very, very little recovery. It's not a very difficult surgery. There is nowadays a valve that can be adjusted from the outside, a magnetic valve. When I started with the surgeries, this was not the case. But now you can adjust the valve magnetically. There are not many settings. This is another issue with an LP shunt. Hence, in other words, it's still pretty crude for what it is. So if you need a more fine setting for your pressure, VP shunt may be a better option for you. That's another reason why neurosurgeons like it better. So there are a little bit of the pros and cons of what an LP shunt is. The other sort of bulk of surgeries or options is what's called a VP shunt. VP shunt is ventricular peritoneal shunt. We've talked about the peritoneal sac. Ventricular means the ventricles, which are the sacs. We have two little sacs, two little balls in the middle of the brain, and this is a lot where fluid goes in and out. So when you do an MRI, they check for the ventricles. So the ventricular peritoneal shunt is basically a catheter is threaded from the ventricles to the lumbar sac. This means that usually either the right side or the left side, usually from the right side, the neurosurgeons try to avoid the left side because that would be going through the communication side of your brain and other, so we say sensitive data, prominent parts of the brain. It is done, but it's more likely done on the right side, and so the neurosurgeon goes into the right side of the brain, then threads it through basically the back of your ear, your neck, all the way in front into your peritoneal sac. And same thing again, you stay in the hospital one night, maybe two. It is a bit uncomfortable. It can vary person to person, and what I mean by that is your head is not used to having, your skull is not used to having a tubing between the bone and the skin, so it bulges, and because the forgive me, the magnetic valve goes behind your ear, but in this area it can bulge up a little bit. It's stretching your skin, so the first day you may not notice it, but then it can be a little bit uncomfortable. Obviously, the sutures in your stomach, just like in the LP shunt, are a bit uncomfortable, but it is a manageable surgery. The big issues with all these surgeries are infection. Those are the biggest issues. VP shunts do get clogged. That is long-term their biggest issue. Catheters, any tubing gets clogged, and they do not last forever. VP shunts that are known to last forever is basically because most likely the patient has had a remission in, most likely, again, I'm not a doctor, but most likely it's because they have had a remission in pseudotumor or the intracranial benign intracranial hypertension, or a diminish in symptoms, and therefore the VP shunt is not needed as much. I don't want to say needed at all, but needed as much. Again, the pressure or gravity when we stand up is what is making these VP shunts work. So as you stand up, they go down. The gauge of the magnetic valve opens. It reads what your pressure is. And when it has reached the setting, whatever the neurosurgeon has set it up, it closes. So if you're still having headaches, you go back to your neurosurgeon, you go back to your ophthalmologist, you are measured and evaluated, and the settings may be changed. There is, depending on the valve that is placed with this VP shunt, you need to be aware of going through an MRI, having an MRI or an MRA, excuse me, because some of the machines, especially the particularly strong ones, may completely wipe out the settings, which means you need to schedule, you should schedule, excuse me, you should schedule an MRI at the same time as you schedule an appointment with your neurosurgeon to have the valve magnetized again to its proper setting. I have gone through this. It's not a big deal. It can be a little bit annoying because depending on the magnetic valve they use, they may need to put some pressure in your head. It's like a little pen, at least the one that I've experienced. It's a little pen and they push against you. My particular issue, I've had a lot of what's called occipital nerve damage. So I have a lot of neuralgia, pain. So the clicking and the pressure hurt, but that was just my issue. There is no need for other people to experience that unless they have my neuralgia. I'm also aware that there is something called a VA shunt, a ventricular atrial shunt, which means that it goes from your, ventricular, from your brain to your atrial area, which is the area around your heart. I have not had this shunt because I was told, and again, that's just the preference of my neurosurgeons, I was told that sometimes this shunt can get too close to your heart or lungs and can cause issues. I was a case where I was studied closely. My tubings tend to travel a lot and did cause trouble, and I'm talking about within my body. So they decided that for this reason the VA shunt was not optimal for me. For my case, you may be very successful with it. Again, I suggest you look at journal studies. I am going to be adding them slowly. Again, this is a very slow process for me to add things like this to the website, but I will. Last but not least, I do want to mention what has been referred to me as a veniogram. Many of you may know it as a stenting, also known as a venous sinus stenting. There are other labels for it, but that is basically very similar of when a stent is placed into the heart of a patient who has issues in the heart, but this is to the brain. And at least in my case, what they did was, it's all done in one procedure. What they did was, was done twice. After some tests, meaning, I don't remember if it was a CAT scan or an MRI. It was an MRA, excuse me. Some shadows were seen in my brain. Hence, they went ahead and through the groin, they inserted a catheter. It was only under local anesthesia. And they were doing under fluoroscopy constant x-ray pictures to see. They went everywhere. In my case, they did not see that I had any issues in the veins that they could see. Now, we have so many veins in the brain that they cannot check all of them, unfortunately. So in my case, they could not put a stent. I was not a candidate for a stent, but I understand many people go this route, and it works very well for them. There are some issues with it. Again, I don't speak from personal experience, so I shy away from it. I suggest you look at it. I was so gracious, and I have been very lucky to be with one of the top interventional radiologists, who are the person who does this in the country and probably the world, doing this. And we basically both cried at the end when we saw that this was not a solution for me. My hopes were up, but it was not. So I stop here. I have more to tell you, but I need to stop. And I do want to tell you that in the future I will be talking about this ice surgery that I mentioned before, which is another surgery usually done by a pediatrician neurosurgeon, basically for children, but it has been done in adults, called ICE. And I thank you for being here. Have a wonderful day. And I do hope that you are taking good care of yourself and surviving through this time. Thank you.